I feel that this North America group might be thinking it's at 10 o'clock because of time change.
Kind of thought that I sent the flyer back again saying that, I mean, the most important people from North America are from the East Coast. So 9 other Tiruthi Anupchon. I corrected that and then I sent the flyer again. It was only the the CST that was kind of messed up. So I asked Jana to try to fix that. But Central Time Zone la romba per kadayadu. It's usually the Eastern time zone la da nare per. So that was fixed. But it's more the KMC students that are going to be attending the session. That's the goal. So the Indian Standard Time is standard at 7:30 Saturday.
எப்போ ஸ்டார்ட் பண்ணலாம்னு சொல்லுங்க.
अमेरिका से बात की थी सर, प्रसाद डालिया सर.
It's about 7:40 p.m. IST. Dr. Prasad, do you want to start or do you want to wait a little bit more?
Start பண்ணிடு. I think you can start.
Hello?
Introduce.
Okay. Hello all. Welcome to the Saturday special session of our Share and Learn initiative. So today's topic is going to be obesity, pathophysiology and management, presented by Dr. Varalaxhmi Niranjan. She is, as you see, she's assistant professor, University of Connecticut. So she is a general internal medicine physician and obesity medicine specialist, and the course director for medical students and internal medicine residents and endocrine fellows on obesity management in University of Connecticut. And she is a KMC alumni, as you all know, from the 1995 batch, trained in the United Kingdom before moving to the United States. And yes, she's a poet. She's a medical columnist and a blogger as well, and has published a few books, including a health education book in Tamil that's called Nalamvara, and an e-cookbook called Supade. So maybe one time I should get to this YouTube channel or anything if she has one to get some good tips to keep the doctor away. No, I don't want that. So she'll be educating us today on the pathophysiology and management of obesity. Welcome, Dr. Varalaxhmi. We are looking forward to your session. Thank you all, and I hope you enjoy the session, and feedbacks are always welcome. And a few ground rules. please mute yourself because there's a lot of disturbance that happens when somebody is presenting, and if you keep yourself unmuted. And of course, you can also shut your videos off. And at the end of the session, there's going to be a 10-minute to 15-minute question and answer session. And you can always post your questions on the chat so that we can always address that. And of course, Dr. Varalaxhmi is going to be giving you her personal email ID to which you can always direct your questions to. So for now, just let's move on and over to Dr. Varalaxhmi.
Thank you, Maithili. Thank you, Prasad. Thank you, KMC, for letting me do this. It really gives me goosebumps. It gives me the pleasant memories of going back to the medical college. So today we'll talk about the obesity. So let's see. So these are my learning objectives because the talk is mainly based for the audience in India. So I'm going to be talking to you about the trends of obesity currently in India and what are the challenges that India is facing now, because we have a double burden in India. One is undernutrition on one side and the other side is the obesity. But you have to remember, even among the people with obesity, there is undernutrition. And then I'm also going to give you some overview on how to risk stratify your patients, because not all patients with obesity are in the same risk category. And then I'll briefly talk about the pathophysiology of the hunger and satiety. We know more about this now than what we know when I was in medical school. So, but that's the most dry topic of the day. So I'll try to, keep all of you awake during that dry period. But then the last few slides will be more on management, like what diet to prescribe to your patients or to your even family members. And then I'll briefly touch upon on the pharmacotherapy, which is not very big right now, but in the next 10 years, 15 years, that's the field the pharmacotherapy is going to grow. So these are the trends currently in India. So if you look in this slide, this one is on obesity in women in India, and this one is in men. But we have included both overweight and obesity. I will be actually talking to you why that is important, especially when you're looking at the population in India. So you can see between 2005 and 6, it was like 12.6%. And now this is like 15 and 16. We're not even, this is like 5 years behind data. It has gone up 5%. And this is among women, and this is among men. 9.7%, and now it has gone up to 19.6. The mean BMI is slowly rising. And if you look where it is, this is basically throughout India. What we used to call Pasumai Purachi, now it has all changed. The picture on this side, it looks like the fall color pictures in Connecticut. If you ever get a chance to visit New England, this is how our trees look like now. And unfortunately, this is how India's obesity trend is growing. Whatever that was green, which is like 5 to 10%, now had gone up to like 15 to 20%. This is in women, but if you look at the men, the same thing is happening. Basically, it's all over India. And of course, it's more in the urban, more in the city population, where there is physical activities disturbed, where there are more fast foods, where the nutrition has changed, and people are busy, there is stress. So there's like 101 reasons for this. But this is the trend. So before we go into the details, why I included the overweight also in the category of talking about obesity for Indian population. That's why you need to know this. These are the criteria we use for classification of obesity, which is based upon BMI. I assume most of you know what BMI is, which is body mass index. And it's calculated by your height and weight. And so this is, I'm not going to read through the slide, but you can see normal is between 19 and 24. But that's for the entire global population. Recently, it was changed for Asians, that the ideal BMI is 23 or under. So in the overweight category, in the general, like global population, 25 to 27 is actually kind of on the higher range for Asians. So that's why we need to include overweight category for assessing the risk, because we see more diabetes in the so-called normal BMI range for Indians. We see this even among the people who have migrated to United States and UK. We also people who are living in India. The classes of obesity, class 1, class 2, class 3, this is the basics. When you are between 30 and 35, it's 1, 35 and 40, it's 2, and more than 40 is 3. We no longer don't want to use the term morbid obesity because it's kind of stigmatizing your patient. So you want to be more respectful and use classes when you are writing your notes or talking to another fellow physician. But remember, this class is also different for Indian population because you're starting at 23. So you have to subtract, like 27 is considered class 1 for Indian population. Why is that? How did we make that decision? This study, this was in 2004. It came in Lancet. You can go back and refer to all these studies. I'll be happy to share the slides. So this was published by WHO. They concluded that South Asians are at much higher risk to develop the complication, mainly diabetes and cardiovascular disease, based upon the BMI. So now the conclusion is we want to look at the BMI or target the BMI of 23. And I want to also post this one, which is the diabetes care study that came in 2019, which is very recent. They talk more about the body composition rather than just the BMI, because there is something called personal fat threshold. You have a BMI of 21, but if your fat threshold is high or fat is high and your threshold is low, you have a higher chance of developing metabolic complication. Again, in the same Lancet, this was published. You can see these two gentlemen, they both are doctors. They both have the same BMI, 22.3. But when they had a DIXA scan, you can see this one has a body fat of 9.1, whereas this one has a body fat of 21.2%. So the one on the left with the 21.2% will have a higher risk of developing diabetes. And of note, the one on the right is a marathon runner. So that's where the physical activity comes. That's where what you eat comes, and how the fat deposition, especially the visceral fat, that causes the metabolic syndrome. So why do we even talk about obesity? Why can't we just have the talks about diabetes, heart disease, all those things? If we just treat the one on the outer circle, diabetes, heart disease, acid reflux, high blood pressure, sleep apnea, cancer, you name it, we are only putting a Band-Aid. We are only fixing the problem, but not actually correcting the root cause for the problem. This is what interested me to go into obesity. I'm a general internist. I've been practicing it for 20 plus years. But what I saw in my patient is the root cause is the obesity, and I'm just fixing with a Band-Aid. So that's when I said, okay, I have to go do a little bit more training in obesity and treat that. And this is just a simple diagram, but if you actually look, there are more complications due to obesity. Whatever specialty you will go after you're finishing your medical school and training, you will end up seeing obesity causing something or other in your specialty. As of today, there are like 256 diseases have been related. If you include COVID, it's 257. Because we know COVID is at a higher risk for people with obesity, and people with obesity are having more ICU admission and more mortality in that group. So that's why I think we need to spend a little bit more time understanding what is obesity and why it's happening and how we can correct it. So we talked about the classes. This is Edmonton Staging System by Canada. They talk more about staging. So this is where we are going in the next couple of years, I would say, because all obesity patients are not in the same category. So if you divide what they are going through, it could be a medical complication, which is like diabetes, heart disease. And then it could be psychological impact. They may be going through depression, anxiety. It may be causing obesity, and obesity may be causing it. And then the last category is the functional. They won't have any problem with their endocrine system, but they'll have knee pain. They'll have hip pain. They cannot move. They'll have shortness of breath. So that's like a mechanical functional component. So you categorize, you stage them depending upon where they are in all these three as stage 1, stage 2, and stage 3. So when you are in stage 0 or stage 1, we are talking prevention. We are talking lifestyle. Whereas when they go to stage 2, it's a secondary prevention. It's no longer a primary prevention. If they have a diagnosis of diabetes, if they have a diagnosis of hypertension, you want to be a little bit more aggressive with them. And then, of course, we have stage 3 and stage 4, where they have end-stage disease, where it's no longer reversible, but we can still help them. So I always like to teach with a case. So I'm going to give you this case. Imagine this is going to be all her diet history is going to be just like how you will encounter in your practice or in your clinic rotations. 56-year female. She has height of 5'2" and weight is 88 kilograms. So if you calculate her BMI, it's 34.38. I've listed her past medical history. Past surgical history is 2 cesarean section. She has a high A1C, say it's 9.1. And she comes to you because she has knee pain. So the knee, reflex, the knee pain reflex would be to treat her for the knee pain with a pain medicine and physical therapy. But we are not fixing the underlying problem. That's where I'm coming to. And these are her list of medication. So now you want to know a little bit more about her weight. If I see her in my clinic, this is what I'll be asking. A little bit more about her weight history. When did she started gaining weight? This is again very typical, especially among postmenopausal women, whether they are in India or overseas. They were initially, doing very well with their weight, but then after the birth of children, slowly starting to gain weight, and they have tried all kinds of diets. She says, oh, I have done many diets. I lose maybe 4 kilos, 5 kilos, and then few months later, I regain. Sometimes more than what I have lost. So why? Why is that happening? Why is she regaining every time after she's trying? That's where the pathophysiology comes. And she doesn't do any exercise. Basically, she says, I'm active. I have 2 children. I have a husband who is working full time, taking care of the house, and I have a lot of stress going on. So this is the history. So I tried to list what typically a 56-year-old Indian woman will be eating. This is again, they think this is healthy because it's all mostly home cooked and they don't eat out often. She says she eats out once a week. She does regular, like 3 dosas with chapati, with chutney or sambar. She has home cooked rice, full meal. And then she may have a snack with a coffee. Snacks, only like on festival, right? That's what they say. But then if you tease out, it could be more often than that. Same with dessert. They may say, oh, it's not often. It's only once in a while. Okay. So now the question we have, the burning question for this talk is why? Why she is regaining? This is what we know about the pathophysiology of appetite regulation. It's very complex, as you can see. I'll try my best not to, complicate it. So I put this down into like a simple way of explaining. If you think brain is in the middle and say appetite is on one end and the energy expenditure is on the other end, we always imagine this as it's an equal sign that is in between. Whatever calories in, calories goes out, and then it's an equal sign. But human body is not like that. There is never an equal sign, right? There's always a feedback loop. There's always an adjustment. Body compensates. So how do that compensation mechanism happen? What are the hormones that are regulating it? So if you see the periphery stimuli comes from different parts of the body, right? So the stomach, that secretes the ghrelin. That's the biggest positive hormone, which actually pushes you to eat. The lucky thing is we all are blessed with a lot of negative hormones. The only positive hormone is ghrelin, you have to remember. All these things, the small intestine, large intestine, pancreas, and the fat cell, whatever they secrete, the idea is to actually lose weight. So when we are trying to help our people, the ghrelin should come down and all these hormones should go up. How will they go up? Whether it could be by what you're eating, it could be by intermittent fasting, it could be by medication. So that's our nutshell. So we want to bring the ghrelin down and we want to increase all the rest of the hormones. So just one big slide on ghrelin, because it's the powerful, strong hunger hormone. It's otherwise called orexogenic hormone. It basically increases the hunger. So we want to know where is it secreted, what is making it secrete. So that's coming from the fundus of the stomach. So that's why when they do sleeve gastrectomy, the hunger goes down. People are able to actually eat less and be happy and lose 100 pounds. That's what happens in a bariatric surgery clinic here. And I'm sure in many parts of India, bariatric surgery is coming up. But that is like, extreme, right? We don't want to go there. So how else we can decrease the ghrelin? When the stomach is empty, ghrelin level increases. That's why we say don't, starve yourself. Even when people are doing fasting, we actually recommend drinking water, drinking a broth or soup, because you're stretching the stomach. Even drinking coffee, when you stretch the stomach, the hunger goes down. And GOAT is an enzyme that actually activates ghrelin. So I'm pretty sure in the next 10 years, we'll have a pharma company coming up with a drug that will actually inhibit this. But we don't have it yet. So I just want to, post this question, trying to be a little bit more interactive. If you know the answer, you can put it in the chat. What is the syndrome that has excess ghrelin? Because that kind of helped us to know more about, ghrelin. Okay, I got the answer. Very good. Prader-Willi syndrome. So this is how we learn, right? When we saw patients with Prader-Willi syndrome and their ghrelin were high, and we noticed that they go and eat anything and everything that they see. It doesn't even have to be an edible, like a food. It can be anything. So the idea is again trying to decrease ghrelin. So this is a busy slide, and I'm not going to read everything in this slide, but this is more for your reference. These are the 4 hormones that come from small and large intestine. Their goal is meal termination. You probably read in your physiology that the cholecystokinin more for the gallbladder, but the idea is also to decrease the appetite. So that's why I normally say when I'm counseling for lifestyle changes, I ask them to eat the fat and protein first before they go to their carbohydrate, because that way they are stimulating their satiety center early. And these are like small tips. You feel satisfied with a smaller meal portion when you stimulate the cholecystokinin. GLP, we know we have now GLP-1 as a oral as well as there, and an injectable. So this is helpful when we know about the hormone, we have a potential target to treat, and we have medications now. And GLP-1 is now like the go-to when you want to treat your diabetes patient, when they have when they no longer can be treated just with metformin. Recent guideline from ADA, American Diabetes Association, is towards doing the GLP-1 as the first line. And the other 2 are not that popular, but studies are going on. If we get oxytocin in the next few years, it's more preferred because less GI side effects. So now moving to the pancreas, we got the stimuli from stomach, we got the stimuli from small and large intestine. Now we are moving to the pancreas. We all know about insulin, but what's the interesting thing about insulin is endogenously when it's secreted, it's a weight loss hormone. But when you and I give it as a prescription to our patient, it's an anabolic hormone and it actually makes them gain weight. So that's why we want to decrease the dose of insulin and actually give them a GLP-1 in addition to help them lose weight if they have obesity and uncontrolled diabetes. Pancreatic polypeptide and amylin are also being studied. And the same with the Prader-Willi syndrome, you actually see low levels of PP. You see high level of ghrelin and low levels of pancreatic polypeptide. Amylin has been used, and some endocrinologists use it along with insulin when they need like really, really high doses of insulin. So now the other place where the periphery from the stimuli comes is the fat cells or adipocytes. If you really look back in the evolution and find out why we all have fat, it's more a storage organ. We need to have fat for the rainy days, when there is a famine, when there is no availability of food. When is that? We don't have it now. Even in middle of the night, you can get order of food. You can nowadays we have food everywhere and all the time, and that's the problem. And that's why there is no need to have excess of fat. This something similar to insulin, leptin also does. It's supposed to actually, the more fat you have, the body is supposed to make you stop eating, but it doesn't because there is leptin resistance. Just like how we have insulin resistance, we develop leptin resistance. So despite the fact body has mechanisms for us to stop obesity from happening, we kind of overcome it, sometimes by our behavior, sometimes by our genetics, sometimes by a combination. So what happens to these hormones? The ghrelin and leptin, these are the big guns in the pathway. What happens is ghrelin kind of stimulate the erexogenic pathway, which is, and I'm not going to again go through this slide in detail, but these are the potential targets again. NPY and AGRP is in the hypothalamus. That stimulates the Y1 and Y5 receptors. The same with the AGRP, it actually blocks the MC4 receptor. And in the satiety pathway, we have these, which is the POMC and CART. You'll be familiar with these in psychiatry or the ADHD population. And then alpha MSH, that's the melanocyte, which is kind of more towards the daytime eating pattern. If you look back in Ayurveda and like Indian literature, I'm talking like pre-Western medicine, they all used to eat only when the sun is there. So because this alpha MSH, when we start eating like late in the night, we are actually disturbing this regulatory pathway. And it's not straightforward. That is what I put it down. What happens in the body is there is constantly one is inhibiting the other and one is stimulating the other. This is typical with any endocrine system. So what I am trying to say at the end of this slides is it is a complex, multifactorial, recurring disease. It is not as simple as many physicians think. Eat less, move more, you will lose. They will lose, but then they'll gain it back. So we have to constantly, help our patients and try to prevent it or treat it. So these are the abbreviations for the information that I used. I think now I'll be moving towards management. I think we are okay with the time. So the reason we need to know the pathophysiology at least a little bit is when we treat our patient, whether it's lifestyle, whether it's behavior therapy, whether it's medication, is we need to know what's going on in their body. And more important is, what are we treating? Are we trying to reverse it completely? Are we shooting for ideal body mass index? Or are we treating the problem? The problem here is the unhealthy fat, the excess fat they have. That is what is causing the problem. It's not the number BMI. That's why it's different in Asians. So our goal is to improve the health, improve the quality of life, and actually make them lose that body fat, that is causing the problem. So if you look back in the literature, in medicine literature, we know 5 to 10% weight loss actually does that. So you don't even need to shoot for the ideal body mass index. And that's what most of the commercial weight loss clinics will be doing. If you Google, there will be so many programs and they will be saying, oh, your height is this, your weight is this, you should be here. But it's almost unrealistic for some of our patients, like our example case. She can never go back to her ideal body mass index. But if she's 88 kilos, if you target and make her lose 8 kilos, her BMI will go down from 34 to 31. And that will help with her knee pain. It will make her diabetes look better, and she will have better energy, and she will also feel good. So that's what is the focus, 5 to 10%. So how do we do this? Again, we'll start from the history and physical and what labs you do and then what you offer. So you will probably do all these, the preliminary, the medical history, surgical history, family history, all those things you'll probably do with any patient. But what I would like to focus a little bit is on the triggers for the weight gain and what is her success, how did she lose in the past, and what is a little bit more on the nutritional history. And more importantly is the sleep pattern and occupation. Like if night shift workers, we see more obesity because again, they change the diurnal pattern. Their body thinks they are still awake during the daytime and the nighttime, so their ghrelin is really, really in excess. And then when you examine them, other than doing their vital signs and general exam, you want to be looking at their neck circumference, and then the Malambati score, that's more for the airway and know their risk for sleep apnea, and waist circumference, which is another area where there is a lot of research among the South Asians. It is sometimes referred as obesity paradox, because you may have a patient with a normal BMI, normal weight, but excess, the belly fat, excess waist circumference or increased waist circumference. And that's where the problem is, because of the visceral fat and insulin resistance, they get more diabetes and they get more cardiovascular disease. So somebody with a normal BMI and increased waist circumference actually has much more higher risk for cardiovascular disease than somebody who has a higher BMI and equal amount of waist circumference. And then I put the body composition, which again may not be available in many of the practices, even among the people who practice in overseas. I have it in my clinic, but if you have it, it is helpful. But it's also now, I think you can get a scale, which kind of a weighing scale, which kind of gives a little bit of estimate on body composition. Chemistry is important because we want to know what their fasting glucose is, how their electrolytes are looking. You want to know their A1C. Do they have pre-diabetes? Do they have diabetes? And pre-diabetes is again is my area of interest, because I sincerely feel like if we correct that stage, we can prevent all the complications of diabetes. And I think there is also an entity where it's pre-diabetes. Which is yet to be actually coined and yet to be identified, a marker, because the islet cell has some capacity to recover. We are missing that time period. Cholesterol panel, you want to do it. But I want to stress a little bit more on the liver enzymes, because in among the South Asians, among the Indians and other Asian population, the non-alcoholic steatohepatosis, NASH, is getting to be a big problem. This is one of the common cause, other than the alcohol, for liver failure and liver transplant need. So that's because of obesity, which is very much preventable. So you can actually calculate the risk by something called FIB4. You can Google it later. Liver enzymes and platelet, that's all you need. And if it's more than 1.6, they are at a higher risk to get liver disease. So, but if you just look at the enzymes alone, you won't know that. That's why you need the platelet also. So thyroid and B12, D, iron, because again, undernutrition is very, very common among the people with obesity. And then insulin level, I do it, fasting insulin level, because I use that to calculate the what we call HOMA-IR, which is the insulin resistance, which will actually help me that pre-diabetes people, I can identify them. If the HOMA-IR is more than 2, it's considered to be higher risk to develop diabetes or pre-diabetes. So what works for obesity? And when you have a patient, what are you going to offer to them? Just remember this mnemonic, it's same. One is the structure. They all need a structure. The structure, they can make it or you can help them form the structure. And that's where these programs are helpful. And then accountability. they should be either accountable to themselves or to their family members or to their physician. So we have to, improve that accountability. We can use all these tools, the food journal apps. There is, MyFitnessPal. They can check their scale every week and report to you, stuff like that. And then M is more towards the metabolic alteration, where we can use intermittent fasting is very, very popular now, especially among Indians. And it does work for Asians and Indians especially. And some population, it doesn't work. And then we can also use, that's where the pharmacotherapy, bariatric surgery, all those tools. And then E is the environmental stimulus control. And that's where the public health comes, like, what foods should be readily available, what advertisements should go on the television, because our children are being affected by this. We are seeing childhood obesity now more. So that's where the environmental package comes. But as physician, we can actually help them to choose some products which are a little bit more healthier than products that are not healthier if they are going to be using meal replacement. And I also put CBT, which is the cognitive behavioral therapy. When I use that terminology, many physicians say, oh, I'm not psych, I cannot do that. But in essence, we do this every single day when we talk to a patient. We just don't use the term CBT because we tell them, you have to exercise, that is a CBT. You give them goal, do 30 minutes a day, and that is a CBT. So we all do that. We just have to know that it is necessary for obesity treatment. So Obesity Medicine Association, that's where I got my board certification. That's that DIP ABOM, that's what it stands for. They recommend these 4 pillars. So nutrition, physical activity, behavior, and then pharmacotherapy, which can be optional. So nutrition, we as medical students, I don't think we are taught a lot on nutrition. So we refer often to dietitians, which is fine, but we should also know a little bit and also make sure that the dietitians are giving the right advice. And sometimes actually patients listen to you more than what they listen to dietitian. So I think we still have to use our, skill level and our ability to guide our patients. What we know is the calorie need is variable. So it's very difficult to tell your patient, okay, eat this many calories, because it's highly variable. It depends upon their activity level. It depends upon their, who they are, what age group they are. So basically, it is not like a number that they can hold on to it and they will lose weight if they just stick to it. But you may want to give them a guideline and stick around it. So if you do 1 or 2 days above, it's okay, but come back to it. When you're forming your structure, you want to base upon a particular calorie level. So when we do the calorie, now the next level goes into is the macronutrients distribution. What do they eat? Do they eat carbohydrate? Do they eat protein? This is what we know from our biochemistry, that kilocalorie per GM, I don't know how many of you remember, fat gives you 9 kilocalorie, whereas carb and protein is 4. Unfortunately or fortunately, now we have to include alcohol because it has become so common to be consumed, and that gives 7 kilocalorie, which is pretty much empty calories, that doesn't have any nutrition. This AMDR stands for the acceptable macronutrient distribution range. That's what your dietitian is basing their, when they are giving the meal plan. But this is different from what RDA is, which is required daily average. So we all need only 130 grams of carb in a day. But say you consume 2000 calorie diet, this will be much higher than the 130. So that's what I'm coming to. Just focusing on AMDR alone will not help your patient. You have to focus on the RDA. Just like one slide on the nutrition. So now this becomes a little bit more interesting, right? This is what our patient was eating, and this is what most of our patients will be eating, and most of us will be eating, or at least we all try to eat here with our breakfast is not usually dosa, but we would love to have it. So I put these for you as like a nutshell, like a picture. If you look at it, this is the carbohydrates in like a serving size. I put 1 dosa. So if you eat 3 dosa, you are consuming 66 grams of carbohydrate there. You can see most of our foods are heavy on carbs. Again, I'm not against eating them. I love eating them, and we should encourage eating home-cooked meals, but we need to educate them about the portion size and about mixing it, balancing it with protein and vegetables and a little bit of healthy fat. So that's what the point is. And if you consume carbs for breakfast, carbs for lunch, and carbs for dinner, the total amount is going to be more than that 130 grams. And this I took actually from the Madras Diabetes Association. You can actually look at in there, it says here Madras Diabetes Research Foundation. This is actually my favorite slide because you can see a lot of the products we consume is for pure indulgence, not necessarily have nutrition. Some of them do have, and it's very, very less calorie. So patient will think, oh, it's only a small amount, but you add up, this becomes, I think if I remember right, it's like 1200 calorie, the entire meal is. So almost like the day's amount is in one meal. So then what do we tell our patients to eat? Whatever they are eating for carbohydrate, it should come from whole grains. If they are eating rice, if they are eating wheat, preferably whole grain, not processed. How do they differentiate? Something that cooks faster, that's processed. If it takes time to cook, then that means it has fiber in it. And it has to be from vegetable and it has to be from fruit. You know, some of my patients will say, oh, I don't eat fruit because it's full of sugar. But then they go and eat real sweet. So fruits are much more healthier, even though they have sugar, because they are naturally occurring sugar than you adding the sugar. The first line here may be like shocking to some of you. Why carbs are not essential? What that sentence means is it is not like the essential amino acid. It's not like absolutely needed for our living. That's why keto diet is still popular and still acceptable, because you can survive because you actually switch to the anaerobic pathway and your fats are now used for fuel. So try to make your patients' daily consumption of carbohydrate about 130 grams per day and cut down gradually. And they can go as low as they can according to their taste, likes, and dislikes. But teach them not to eat processed, ready to eat, ready-made available fast foods and junk foods. I think that's the first and foremost teaching we have to tell them. So proteins, what do we know about proteins? They are very good for your weight loss. If you look at it, you want to maintain your weight, you need only like 0.4 to 0.8 grams per kilogram. But your patient wants to lose weight, you want to increase the protein. But you preferably want to do a balanced, more on plant-based as well as a little bit on animal-based if you consume animal-based product. But you don't want to do totally animal-based because that may have, depending upon how they process the animal meat, that may cause problems. So the immediate response I'll get from vegetarians is not enough protein. So this is, again, I just want to put it, there is enough protein in vegetarian food, but you just have to be mindful and include that in every meal. And what do we know about fat? Again, there's a lot of misconception about fat. Fats are healthy as long as you consume them in a small amount and you are eating them to actually promote satiety, not for indulgence. And naturally occurring fat, like nuts and seeds, are much more healthier than processed oils. And, so the deep fried foods to be avoided, but you can have nuts, small portion size. And this is another picture I want to show, which is purely plant-based, doesn't include any animal product. So you can still promote healthy eating, just, portioning their carbohydrates, and they should include that so that they will feel satisfied that they are eating it. But in this picture, you can see this is all the carbs. The rest is all fruits and vegetables and beans. So this is actually from Endocrine Practice 2016, which was actually the guideline issued by American Association of Clinical Endocrinologists. So they have 3 pillars. They didn't include medication in this because it's a lifestyle approach. So you want to cut down their meal plan for about 500 to 750 kilocalorie from what they are eating now. It can be any diet plan. It doesn't have to be, oh, Mediterranean is good. Oh, keto is good. Oh, high protein is good. No, it doesn't have to have a name. They just have to eat less, balanced, and have a lifestyle change and not just a diet. And you can include dietitian, you can include health coach, you can include family member, everybody in this process. I'm going to actually talk more on physical activity and behavioral therapy in the next slides. So this is just one slide I just want to say, because I know there are a lot of protein shakes and protein bars. I think in India, the Herbalife is very popular. So there are some studies to show that it works, only because I think it actually works as a behavioral therapy. They are satisfied by just drinking that drink and not they are indulging. So I do recommend that, especially for those who are in a fast-paced world and they don't have enough time to meal prep every single meal. So then I ask them to use it as a quick snack or a quick breakfast. So these 2 slides, again, it's just more for reference. What I'm trying to get out of this is every single diet, the fat diet that is out there. These are the most popular in US, but I'm sure some of them are popular in India too. And you may have more new names to it. Everything has a pros and cons. And so our role is to teach the patient that you learn from the diet. You want to do the diet, do it. I'm not going to say no, because even if I say no, you're going to do it. But learn from it. Why are you losing it when you're on it? But then as soon as you stop, why are you gaining? Because you are not eating the same portion size. You're not eating the same combination of food. So that's what I say to my patients. And this is something about the apps and programs. Again, there is pros and cons in every single of them, one of them. But you want to learn from the good things about these apps. And you can use them as tools, but they alone will not do the magic. So I think we have a few more slides. I hope we have the time because we started a few minutes late. But whenever you want to stop, you can let me know and I can stop for questions and stuff. So physical activity, oftentimes, especially among Indian patients, what we feel, what I hear is, I don't have time or I don't go to gym. You don't have to. So you can put them into these 4 categories. One is the fitness, like how many jumping jacks you can do, how many times you can sit on the floor and get up. That's a fitness. Then the next one is the movement, just moving. For our patient, she has knee pain. I cannot ask her to sit on the floor and get up. It's more about moving for her. And then we have planned exercise, which is like 30 minutes of walking around the block. And then there is something called NEAT, which is non-exercise associated thermogenesis. That's why some people, they don't do any exercise, but they are lean because their NEAT is high. This is different from your medical exam NEAT. It's a different spelling. But I just want you to know physical activity, compressor, all these things. So when you're treating your patient, you want to tell them the frequency, intensity, time, and type of exercise, and they have to enjoy it. So that's the mnemonic for the FIT. So what are the guidelines for Indians for the physical activity? We have 2 sets of guidelines. One is issued by WHO, which is 60 minutes of moderate to vigorous intensity activity daily for young people, 5 to 17 years of age. And it's the same by the Asian, the consensus statement for Asian Indians. This consensus statement came from all the associations in India, including the Diabetes Association, the Physical Activity Sports Association, all of that. So when you go to the next category people, 18 to 64, or even more than 65, the recommendations slightly differ, but bottom line is you want at least 150 minutes per week. If they can do more, then it will be 60 minutes daily. Among that, 30 minutes should be moderate intense activity, 15 minutes of household chores or work-related walking activity, and 15 minutes of muscle strengthening. That could be a yoga, that could be an asana, that could be a plank, could be any form of strength training activity. Again, you want to grade it. If your patient cannot move at all, you want to start slow and then slowly build it up to this. And this is again the guidelines for Americans, which is not any different. It's just that we have this and here. We want 150 minutes and 2 times a week of strength training. The talk test is something that will help to differentiate moderate versus vigorous, because our exercise threshold is different. So when you start, if you're able to talk, that's your moderate intensive activity. But if you're not able to talk, then that's a vigorous activity. So this is the components of CBT. As I said, we ask them to check their blood sugar. That's a CBT. We give them a glucometer. We tell them to avoid the stimulus. Don't buy the wrong foods, we tell them. So we do the CBT all the time in our clinic. These are all the 10 components of CBT. And when I see my patient, I don't fix in my head, okay, this is what I'm going to talk about. It really depends upon how the flow of conversation is. If they are saying, oh, I have guests at home and I'm constantly cooking and eating, so then I talk about that. That would be more like stimulus control or, problem solving. If holidays are coming, then I'll be talking about contingency management, like, how to manage Diwali, how to manage the Thanksgiving holiday for us. So that's how the conversation go. So you don't have to be doing all of them. You can do one or more, and which I think we all do anyway. So now the next pillar is the pharmacotherapy. There are only few medications we can use, but more than using the pharmacotherapy, I want to stress these 2 slides would be talking about what are the medications that we use commonly may cause increased body weight. Can we look up for an alternative for our patient? Because for our example, our patient was on atenolol, but some beta blockers, they actually increase the body weight. Carvedilol, for that matter, actually does not do that. It's a weight neutral. Same way with the calcium channel blocker, they can increase the body weight. Insulin, we know about it. That's why I said we should use the GLP-1 more. Gabapentin, that can increase. So if a pain is not managed with gabapentin, you may not want to continue it. Some antidepressants can increase, whereas bupropion can cause weight loss. So you want to choose a different alternative. Antihistaminics, very commonly used. And sometimes when they start it, they just are on it every single day. So you don't need it, you use it as needed basis. So these are all some of the meds increase body weight. And these are all some of the meds that decrease body weight. So when there is an opportunity, change the medicine to the one that may be helping them to lose body weight when they have obesity as a root cause. So for pharmacotherapy, we have strict criteria, strict guidelines. BMI more than 30 with or without comorbidity, we can use. BMI more than 27 with comorbidity, we can use. And if there is no clinical improvement after 12 weeks, you have to change it and consider different medication. That's the guideline. And this slide will actually tell you, just like how you treat any other disease. Like you have a patient with high blood pressure, you start a medication, you recheck. If that is control, you continue. Not control, you titrate it. If they have side effect, you stop. It's the same phenomenon you do in the pharmacotherapy of obesity. The only thing I want to emphasize is if there is no weight loss, you do not want to continue. If they are not losing in 3 to 5% weight loss in 3 months, you want to stop the medicine. If they are losing, you can continue. So these are the 5 medications we have. Again, I'm not going to talk in details about these. Sympathomimetic amines, which is not very popular to be used globally. I use in my clinic in selected population because of the side effect profile. It causes more cardiac abnormalities. It can have addiction potential. So you don't want to use unless you have that structure to actually help your patient. But the other one, the opioid antagonist and norepinephrine, that's the bupropion and naltrexone combination I use a lot. And then GLP-1 agonist, a lot of times used in diabetes population. Lipase inhibitor, which is the Orlistat here. I don't know what it's called in India. It's over the counter here. But that's not very well tolerated. It's like it makes you excrete fat, basically. So this is the obesity treatment pyramid. You want to step up as the intensity of the disease is high. So initially we'll start with lifestyle modification, and then we address the intermittent fasting, meal replacement, and then I start the pharmacotherapy. And after that, I refer to the bariatric surgery if they are still needing to lose the body weight. So coming back to our case, this was our case. So what will I offer to her is mostly lifestyle. I took this picture actually from the Kaveri Hospital blog. They have a very nice diabetic regimen. So I thought if this gives a pictorial, example of how the afternoon meal that she has, she can have all the things that she was having, sambar, rasam, and curry and all that stuff, but the portion size of the rice is diminished. That's the biggest change. And breakfast, I think I would say instead of 3, cut down to 2. And then for snacking, don't do the biscuits, it's processed. Don't do the snacks, don't do the fried snacks, the tattai and murukku, go for the fruit. And then dinner, again, I cut down the chapati number, and then I'll encourage some physical activity. You may want to refer her to a physical therapist. You want to talk to her about reducing the sedentary activity. Don't sit and watch TV. If you want to watch the TV, walk around in your living room and watch the TV. And you may want to actually follow up in a few months. That would be my suggestion for her. And I think I'm going to be ending the presentation with a Thirukural, because I'm very fond of Thirukural. And there are actually 10 Kural on Marundu Adhigaram, which actually talks about, all the things that we do. So, Attradu Arindu Kadaipidithu Maralla Thuikka Thuvara Pasithu. It says it all. Basically, you need to, what you should be eating, when you should be eating, and how you should be eating. So only those that are compatible to you. If it's causing trouble, if it's causing indigestion, if it's causing diabetes, you should avoid it. Should be in moderation, as well as it should be right after knowing that the previous meal has digested. So that's all I have, and I can take questions.
If no one is going, can I go?
Yeah, sure.
For question.
I think they're coming in the chat, but sure.
I see. Okay. Thanks, Dr. Varalaxhmi. It's an important topic, and I'm so thankful that you addressed this. My question is, I see, I live in the United States too. So it's the outcome. What do you, with all these things that you do, the measures that you do, what is the success percentage? And that actually was discouraging to me, and that's why I didn't go into obesity medicine. So as an internist, so what do you see as far as success percentage?
Okay, so I actually just recently presented my abstract, so I know exactly what my success rate in my clinic is. So I'm targeting more 5% and 10% weight loss. So if that's how I measure my research studies are based upon that. And what I found is the more number of visits they have with me, the success rate is high. And the average number is about 5 to 7 visits with me. So in other words, constant reinforcement is needed. And though in those population who have come to me 5 or 6 more times, it's about 50% of them actually lose the 5%, and about 40% of them lose the 10%. And it takes about, in my clinic data, it takes about 200 days to actually see 5% weight loss, and 330 days, almost a year, for 10% weight loss. So it's not a quick fix. And I think we are fortunate here, at least there is a continuity here. And I know sometimes in India, that's a problem. Your patient do not come back to you and they might go to somebody else. So I think we have to do both. If you have the continuity approach, definitely you can see the outcome coming out. If you do not have the continuity, you're just seeing them once and you don't know, you want to make use of that one visit and educate them. And I'll tell you, if they see the scale moving, they'll come back to you. And that's what happens with these patients. But I do have a lot of no-show also. And I think that's because they don't come back. That's because of the motivation issue. And I think that's where the behavioral therapy comes a big component, which I do not have a behavioral therapist in my clinic. But if possible, I think in India, it's a little bit more easier to have like a multi-center approach with a dietitian and behavioral therapist. Major hospitals, I think they do that.
Okay, thank you. I think that is the main thing I see. The motivation is the biggest issue, and I wonder if there is any difference, like genetic
Predisposition,
propensity, or predisposition for
I
that
think
as
no,
well.
I think it is just like, you know, the same with, I mean, I always say when I teach my students, I can never give up on my students. I can never give up on my patients, because I think it is also, we have to make use of every visit we have with them. And the more constantly they hear, they get motivated. But motivation may be slow and steady in some, and some are already motivated. So when I see them, I also look at why they want to lose weight, and then I hold on to that and have the conversation. So I also see there are some other questions here. Some are actually asked privately to me, but I can just bring that over. One is about need. So some people say even if they eat too much, they don't gain weight. And I think the theory is, what we think is definitely they have more of the need, because if you actually carefully observe those people, they move a lot more. They may not be doing an exercise per se, but they're constantly doing something. So that may be contributing to them actually able to, you know, keep the weight, not gaining it. And then it is also possible what they are eating. You know, they may be eating a big portion size, but if they are eating healthy, then that could be, you know, not causing the gain. Again, in obesity, it's still evolving. We know more about it now than what we know 10 years ago. And I'm pretty sure in the next 10 years, we'll know even more. The other thought is like a set point theory that's coming up. We all have a set point in our body weight. And once your body reaches that, the body actually tries you to, you know, not lose any more. So that's the problem. And then I have another question asking about how relevant is the lateral hypothalamus, which is the feeding center, and then the ventromedial hypothalamus, which is the satiety center. There is a theory that was proposed in 1952 and in the current scenario of obesity. Again, these theories are useful. The feeding center and satiety center are still there, we know. But what we are doing right now, in our general category is, are we stimulating the feeding center? Are we stimulating the satiety center by eating? So that's where my behavioral therapy comes to my patient. You know, I always educate them to eat small portion size and then wait for 10 minutes before going for second. Because that when the satiety center is stimulated, and now you no longer want to eat that seconds. So that's how I, propose it. But is there an entity as hypothalamic obesity? Is there an entity like a genetic reason for obesity? So the answer is yes, there are predisposition genetically, but the population we saw, like, you see whatever, 25% in India, that genetic will be like less than 1%. So that's not your, bread and butter. That's not every single patient you're seeing in your clinic. That's like a rare entity. So I think we have to treat the big elephant in the room rather than looking for zebras. Okay, that's a good question. Do we need to run leptin and ghrelin test, which will it be useful to treat appropriately? Yes, in some cases. Again, I do not do them on every single patient I see, because most often the ghrelin, the history will tell me the answer. So again, cost effectively, if you elicit good history, you will know whether the ghrelin is up or not. The history would be, I just ate, in 2 hours, I'm hungry again, so I have to eat. Then I know that ghrelin is high. I don't need a blood test to show it. But in some people, it is useful, especially the leptin level, because of the leptin resistance. So I do not do it on a regular basis, but like those rare people, like you have done everything, they are doing everything what you are asking them to do, they are still not losing. That's when I order those tests. And I think pharmacotherapy is only one part of it. I know we want to, for other medications, like for example, if you see a diabetes patient with a A1C of 10, you're not going to say, okay, change your lifestyle and come back and see me, and then I'll decide whether I'll start you on a medication. So one school of thought is, why we do the same thing for obesity? Why can't we treat them right away with a medication? The answer to that is we do not have very potent medication, first of all. And second is the lifestyle has to work in order for the medication to work. So you need to be focusing more on the lifestyle and use the pharmacotherapy as a tool. So the classic example I say is, it's like sitting in a chair with 4 legs. All those 4 legs have to be sturdy. You kind of know what those 4 legs are. I told you in the pillars. But sometimes you don't need a chair. You can sit in a stool with 3 legs. So for you, I'm going to make you sit in the 3 legs without the drugs. But if it doesn't work, we'll make you sit in the chair. This is what I tell my patient. So now I know I was waiting for this question. Is keto diet sustainable? Because I know a lot of fad diets are there and people are very, very keen on doing it. The keto diet is based upon very, very low carbohydrates. It's basically, I can actually stop share, right? So keto diet is basically, what it means is 20 grams of carb. Some people actually do 50 grams of carb, 20 to 50. So like I said, carbohydrate is not an essential nutrient. So you can do keto. And the studies, what we did, what we know literature-wise is on epilepsy. It works. And that's what is the stepping stone for trying keto. But is it sustainable? It actually depends upon the patient. I have some patient who, especially who are meat-eating people, they are saying they can do that. But vegetarians, it's very, very hard. And some people say, no, I get tired of it. I cannot keep eating eggs and meat every single day. So it really depends upon the patient. So I personally don't recommend keto, but if they come to me and say, I want to start keto, I say, okay, start. But then come back in 2 months and we'll talk about what you learned in it, whether you can do it forever or you want to change it. So that is how because then I am actually engaging them and they'll come back to me. If I say, no, don't do keto, they're not going to come back to me. They'll probably do keto, lose, but then not stop keto and then gain. So I want to make use of, my interaction with them and be able to help them.
So this is Maitri here. So how about the vegan diet? The vegan is another trend and the fad that's going on right now.
Yes. So vegan, again, vegan, you can say vegan, or you can say plant-based, whole food plant-based. I prefer to call it whole food plant-based because when you use vegan terminology, again, I'm going to talk more in terms of what a typical an unhealthy vegan would be in United States, which will be a potato chips and a Coke. That's vegan. So we know that doesn't cause weight loss, and in fact, it's not healthy. But if you do whole food plant-based, will that cause weight loss? Yes. Again, it depends upon the patient. And if you think about Indian foods, most Indians are vegetarian and they use animal product, but it's only milk and yogurt. But we do see obesity in Indian population too. So that's where I think just not one diet is you can label. I think in my slide, I have put the pros and cons for both keto and vegan. So vegan will also help on people who have heavily consuming, again, if you say whole food plant-based, heavily consuming processed food, if they are using a lot of animal protein, and if they change, yes, they will lose weight. And there is some studies to actually show the cardiovascular benefits on the plant-based. So typically what I say is, again, remember the 4 Ps I say. One is mostly plants. You can include occasionally animal product, but mostly plants. And then portion size, that's very important. And then you also want to include the physical activity, that's another P. And then the meal planning and protein is the other P. That's the 4P. So you want to include the protein, which can be, again, mostly plants, plant-based, and then include the portion size. I like these mnemonics because that way patients remember it.
I came across something called planetary diet. Have you heard of that?
No.
That was like last year. I think about 400 scientists across the world came together, and it was more designed for being environmental friendly. And that sounded more like, just like what you're saying.
Yeah.
More plant heavy, less meat, more balanced, so to speak.
More balanced. And like if you look at paleo, that is also similar. Paleo is basically whatever, they do include meat, but they eat only what, the cavemen ate. So in other words, they are avoiding all the processed food, which is not a bad thing. So any diet is fine as long as you learn from that diet. But what is key, both for ourselves, family members, and patient, is it sustainable? Is it a lifestyle modification? It shouldn't be, okay, I'll do this for a month and then I go back to what I was eating. No, that doesn't work. If you want to do this for a long period, possibly for entire life, then maybe a situation you're traveling and you're you have to consume something other than what you normally do. That's fine. But once you are back to your routine, you want to have a structure. So there are some other questions. I'm going to combine these two. What do you recommend for pre-diabetes, normal BMI, but has increased waist circumference? And then the next question is pre-diabetic stage reversible by weight loss? So yes, to Shivani, pre-diabetes is reversible. Even diabetes is reversible, especially in the early phase, especially when it's new onset. Recently in the United Kingdom, they actually published data on this. The number they call, I forgot the name, I think it's Dr. Roy. He calls this as the personal fat threshold. So his study showed 15 kilos weight loss. Actually, he reversed many diabetes. So if we target 15 kilos, again, this is for somebody who can lose 15 kilos, not to the one that has a normal BMI or a low BMI. For the higher BMI patient, if they lose 15 kilos, the diabetes can be reversed, but they have to be motivated for that. And for pre-diabetes, it's much, much lesser. And then when you come to the normal BMI, that's where the fat threshold comes. That's where my slide was talking about how do you define the normal BMI? If it's Indian, it should be less than 23. And if they are more than that, they need to lose weight. And they need to lose the waist, the truncal obesity. So that's where the intermittent fasting helps. That's where cutting down the carbs helps. And also, of course, physical activity and strength training, that helps.
Hi, I'm sorry if I need to interrupt, but then looks like we are about a way ahead in time.
Yeah.
And I know the Indian Standard Time for dinner is right now, I guess, although it's not healthy. Sorry. So I just wanted to kind of say thank you to you. It was a great lecture, great information. And peeps, whoever want to get more information can directly contact Dr. Varalaxhmi, and she could give you some good advice, as the trend is right now weight loss and going to the size 0 or the -1. Everybody can become Kareena Kapoor. It's kind of like about 6 months. So thank you so much. And I apologize once again for the time change and the confusion. And but I kept the standard at 7:30 IST, and I thought people could kind of make their own mind about that. Sorry about the confusion. The next lecture session is going to be on November 21st, if I'm right. And until then, adios, amigos, and see you next time. Thank you all, and thank you for your patience. And sorry about the confusion again. Thank you.
Thank you.